Sorry. I'm going to talk about the severe deformity, hip deformity. So first case, this patient had a severe hip and knee flexion contracture. The disease is CFD, congenital femoral deficiency. So it's a difficult condition because after femoral lengthening, many complications occur. Hip knee flexion contracture, hip subluxation, dislocation, partial dislocation, fracture after removal. Many complications should be considered. In this patient was treated at another hospital. So infected and fracture and malunion occurred. So for this patient had severe limb and pain. And as you can see, the leg length discrepancy, hip flexion contracture and knee flexion contracture, and femoral deformity, tibial deformity, ankle deformity. So many deformities are there. So first of all, we did extended release of flexion contracture of hip and knee joint, and after 1 month later, gradual lengthening and correction was performed using a fixator. So first of all, lateral wide incision for this patient, first lateral resected, and proximal for hip, sartorius, rectus femoris, iliopsoas cut, and psoas tendon cut. As you can see, the biceps tendon lengthened, gastrocnemius, posterior capsule release. Medial side, similarly, gastrocnemius medial head was cut, and posterior capsule release was done. So as you can see, the medial condyle here, and you can see through the hip joint posteriorly to the lateral side. So by this wide procedure, this patient hip and knee flexion contractures resolved. So 1 month later, acute correction and gradual lengthening were performed. So I used for this patient modular raised hip system. This device is available only in facility in Japan. It has a knee joint and hip joint can move using this fixator, and it can combine Elizalov and Taylor special frame. So first of all, knee point decided, and next femoral external fixation was applied, and tibial correction was performed, and pelvic screws were placed, and extension bar was placed to prevent recurrence. So as you can see, the smooth movement of hip and knee joint. So immediately after surgery, the patient let the patient walk. This patient couldn't walk due to severe pain and limb before surgery. And after lengthening, we removed the joint, and okay. Finally, flexion and extension is very good. So it's a difficult condition because this patient is congenital femoral deficiency. The next patient, left hip deformity after open reduction, and after open reduction pembert osteotomy at 3 years and 9 years. So as you can see, the knee in gait, triangular gait, severe pain. She couldn't walk for a long distance. As you can see, impossible to squat and to sit cross-legged. Limitation of flexion, abduction, and external rotation. So you can see, like this slide, this patient can't abduct. So many patients will choose a Chiari and femoral valgus osteotomy, but I didn't choose it because this cannot improve function. My choice is posterior rotation osteotomy with dilatation and valgus. As you can see, this patient can abduct well. So congruity improved, head became spherical, spur disappeared, and abduction improved. As you can see, acetabular coverage improved, and neck shaft angle improved, leg was lengthened. As you can see, femoral neck lengthened and external rotation improved by the dilatation osteotomy. Greater trochanter distalization was completed and abduction improved. After surgery, this patient pain disappeared and gait improved. This patient became possible to walk for a long distance. As you can see, the very much improvement of the hip joint. Abduction is well, and flexion, external rotation improved. Okay, so as you can see, the hip abduction is very good. Internal rotation and external rotation. Okay, so after surgery, so this is 16 years old, and at 20 years old, the scoliosis, no scoliosis, and length is good. Next patient is similar, septic arthritis. After drainage and oral DVO pemberton was performed 5 years of age. But as you can see, the deformity, and so X-leg deformity. This patient had pain, severe pain. So similarly, posterior rotation osteotomy and valgus and lengthened. So as you can see, the X-leg was corrected simultaneously. So at the time of 20 years, the alignment is very good and hip congruity is much improved. Now this is a similar case after SCFE, left hip deformity after pinning. So I did this patient, the posterior part is intact, so anterior rotation osteotomy with progress and internal rotation combined. And pelvic, the coverage is poor, so triple osteotomy was done. So this patient's hip joint much improved and no pain, and range of motion improved. So next patient is as I said, Larsen syndrome. The typical Larsen syndrome, you can see the hip hyperextension, bilateral knee dislocation, and left hip dislocation, and bilateral club feet. So we used to use VI-plasty, but I didn't use VI-plasty now because to prevent extensor weakness and extension lag seen, it's commonly seen in VI-plasty. So femoral shortening I use. So posterior medial release for club feet and or DVO pelvic osteotomy was performed for left hip dislocation. So as you can see, the before surgery here, so hyperextended. So goal of the flexion is 90 degrees because this patient have to sit well. After surgery, knee extended, extension contracture recovered, and posterior medial release was performed 1 year, 4 months. At the time of 1 year, 11 months, open reduction, DVO pemberton osteotomy were performed for this patient. So 2 years, at 2 years, 8 months. So you can see that this patient can stand on the floor by herself. So the range of motion is very good. The last patient, it's the most difficult condition of the extension contracture of abduction contractures. This patient is CP. Bilateral dislocation was treated by cross deduction at another hospital, but it failed. So as you can see, this patient's wheelchair has 3 floors, and this patient can't bend the body, so very big wheelchair, and it's difficult to take care of her. As you can see, the abduction flexion contracture and extension degree is minus 100 degrees. So this is a dislocated hip. Okay. As the time of right hip surgery, so you can see the hip was hyperextended and flexion, extension. So it's difficult to hold the body. So under epidural anesthesia, I have to take somebody must hold the leg. Anyway, so I did the under wide incisions, on these, muscular release was performed. Fascial lateral resected, sartorius rectus ilius plus cut, and these muscles were lengthened and cut, and femoral valves and extension osteotomy was performed proximally. For this patient, VI+T and anterior capsular release were performed simultaneously. And as you can see, this deformity was corrected well. And after 6 months later, I did surgery for left hip. So severely dislocated on the left hip. So in this patient, similarly wide exposure is necessary. For knee, VI fascial lateral resected and VI+T and anterior capsular release was done. And after that, open reduction, femoral osteotomy and periodic osteotomy was performed. As you can see, the shape of the hip, femoral head is very good. So this is range of motion of this patient, not hyperextended. The range of motion is much better after surgery. So post-operatively, this patient can sit. So flexion is about 90 degrees. So change and remove the 2 floors for this patient, and she can sit well. So after surgery, so alignment is much improved for this patient. Thank you for your attention.